My talk, what I assigned is painful stiff classification. We have primary and secondary. And primary, we all know that there is a etiology is most of the time we don't know. And secondary, maybe predisposing causes are uncontrolled diabetes, and we have some hypothyroid conditions, dupuytrenal contractures. They have predisposing factors for development of frozen shoulder or adhesive capsulitis. We have secondary stiff shoulder. Maybe it is because of post surgery, after surgery of rotator cuff, instability surgeries. We have loose bodies, chondral lesions, some extra articular causes, including scar formation around the shoulder joint because of burn. There is a muscle tightness, or there might be heterotrophic ossification. Some neurological condition like brachial plexus injuries, and because of head injuries, we have a stiff shoulder. Talk about the clinical diagnosis in idiopathic primary is a shoulder pain and stiffness more than 3 weeks, and of course range of motion started decreasing. At least 50% of range of motion, passive restriction in external abduction as by Sakos is we include in the idiopathic adhesive capsulitis, and almost in terms of degrees it is more than 30 degree in 2 or more planes. And radiograph is normal, and no arthritic changes is there. And we all see in our clinical practice that patient used to come with the MR scan with there is always most of the time we see partial thickness tear of supraspinatus with adhesive capsulitis, and it is really a challenge. If you put your scope in such type of cases, you will end up in a problem. That's why in such type of MRI reportings, you primary diagnosis is adhesive capsulitis. Don't give any importance to partial thickness tear. It might be signal intensity changes. If we go through pathophysiology, what is the problem with what is their pathology in the adhesive capsulitis? It is mainly synovitis and in the rotator cuff interval. Later on, there is a contracture of rotator interval tissues, coracohumeral and superior or inferior glenohumeral ligament, and it is because of increased excessive production of type 3 collagen, especially myofibroblast. If we see the anatomy, there is a contracture in the rotator cuff interval, and there is also thickening of the capsule and the thickening of the middle and inferior glenohumeral ligament. It's you can easily appreciate normal is all white, and if it is a red inflamed, it is a frozen shoulder. And all we know that we have 3 phases: freezing, frozen, thawing phase. It's last up to maybe 3 years. Initially, the pain starts with in a adhesive capsulitis, and difficult to differentiate between it is a frozen shoulder or it is a impingement in first initial month of symptoms, and later on that rotation get restricted. First rotation goes is external rotation, later on the internal rotation start decreasing. And in third phase, significant loss of motion and pain, stiffness at the end of the motion, minimal synovitis, and there is an increased thickness of axillary fold. And later on, profound stiffness, minimal pain. This is the last phase, motion loss, but start to improve slowly. As per literature, all the frozen shoulder get recovered by itself. Some literature suggests complete recovery in 2 years. Some says that after 4 years, almost normal function and minimal pain is there. Again, 94% of idiopathic frozen shoulder recovered by itself. But still, some literature suggests that still, even after 7 years, 50% of patients showed some limitation of movement and stiffness is there. What all the treatment is available for? Initially it's a physiotherapy. Sometimes we used to give NSAIDs also, and at the right time, an initial phase of adhesive capsulitis, intra-articular steroid works well, and there is a literature regarding distension arthrography, manipulation under anesthesia, and after that capsular release. I do intra-articular steroid under USG guided, so that I can put my steroid in a right place. For arthroscopic release, if there is a even after 3 months of physiotherapy and medication, there is a continuous loss of movement, patient find difficulty in daily activities, Second is after failure of manipulation under anesthesia. And third is if there is a osteoporosis and chances of fracture if you plan for manipulation under anesthesia. This is all my indications for arthroscopic capsular release. Ideal time is again not in the thawing phase, it's the frozen phase, in between symptoms starting from 3 to 12 months, maybe in between 5 to 6 months is the ideal time for arthroscopic release. It can be done in any in a B chair and lateral position. It's all depends upon your training, and you require a pump, and the arthroscope and radio frequency ablator is very important in such type of patients, because joint is already tight, vision is difficult, entering the joint is again a challenging task. The steps are, we just do first synovectomy, then start releasing the rotator cuff interval. There is, we do coracohumeral ligament release, and then comes on the superior inferior glenohumeral ligament release, and last we need little bit gentle manipulation like arthroscopic stiff knee release. A short video how I do. I start just use the radio frequency ablator, releasing the middle glenohumeral ligament and inferior glenohumeral ligament. You need I think the video is not working. But while it's doing arthroscopic release, you have to be a little bit gentle. Otherwise, in a tight joint, you may scuff your cartilage of the glenoid and humeral head, and need proper assistance. And be careful while cutting the inferior pole, because it might because axial nerve is very close to that, and you may use your scissor arthroscopic scissor, or radio pointed vent of radio frequency ablator. This is how it's a posterior capsular last, and this is how I do my arthroscopic release. In inferior is 6 o'clock position, as I already explained. You can use your punch from arthroscopic basket, and you can use pointed radio frequency ablator to release the inferior axillary pouch or IATF. In my practice, in stage 3-4, I put first intraarticular steroid injection and advise them supervised physiotherapy program. If it doesn't improve, then I do arthroscopic release, and after that we start aggressive physiotherapy. Frequency repetitions are very important. Capsular stretching, anterior, posterior, and abduction is there. This is how we get proper range of motion if physiotherapy is properly done. And if we talk about post-traumatic shoulder stiffness, of course, it's we can divide into 3 major groups: extra-articular adhesions, direct injury through intra-articular structures like loose bodies, tendon ruptures and fractures, and scarring because of damage to capsules and damage to muscle. Out of these, most important stiffness we find in our practice is in the rotator cuff, mainly in abduction, and sometimes because of the sutures, remaining sutures, they create the fibrosis in the subacromial space, and patient really find difficulty in abduction. Incidence is around 32%, and most of the time the reason is the post-operative immobilization. It is the glenohumeral as well as subacromial adhesions, and diabetes and sometimes underlying predisposing factors may play a role in stiffness. Again, this is what we categorized in rotator cuff repair: stiffness without retear, stiffness with retear, with untreated osteoarthritis, and sometimes it's with the injury to deltoid and neuroscope. In instability, we see a lot of patients with stiffness, especially in the external rotation, because of the position of immobilization. As we do use a pouch arms legs and the shoulder arm immobilizer, they keep the limb in the internal rotation. That's why nowadays we emphasize on use a sling with the pillow in between to keep the operated limb in the little bit neutral or external rotation. And the reason for the development of fibrosis is always around the coracohumeral ligament between the cuff and the acromion and rotator cuff interval is there. In conclusion, early diagnosis is important to intervene, and the secondary causes, whether it is a arthritis, whether it is because of some trauma in the cartilage, loose bodies, calcific tendinitis, it is always necessary to rule out, get the proper investigations. In the primary frozen shoulder, conservative treatment should be the first choice. If doesn't improve, then arthroscopic release is the ideal nowadays. And stiff and secondary stiff shoulder, identifying the cause and treating the underlying cause is essential. Thank you. Thank you for attention.